Yeah. Sarah processed on Instagram that makes me feel even better.
Do we got class today?
Hi, everybody. I'm just running a couple minutes late. I'm here. We have class. I'm getting everything started up. Okay. Go ahead and click in here. And so we were talking about anxiety disorders on Wednesday. So we're gonna keep on going with that. Alrighty. And so we had talked about this and I deleted a slide here. I had a slide about phobic fear and anxiety and like y'all don't need to know that. So I just took it out. Oh. Thanks for letting me know. Let's see what's happening with the projector. You know, it's not one thing, it's another. If someone did something stupid and unhooked it from the projector. No, looks like everything's plugged in where it's supposed to be. Let me try the settings on this computer. There we go. All right. Took a little doing, but we got it. Thanks for letting me know that that was happening. All righty. And there we go. Okay.
It's an important
So I now
distinction.
have, and hopefully I can get, oh, I turned down the sound because of the buzzing. I have a quick video talking about the difference between panic versus phobia that I thought was pretty interesting. So I'm gonna go ahead and play that for y'all.
There's an important distinction between phobia and panic disorder. So someone who has an airplane phobia is generally afraid that the airplane is going to crash. The person who has panic disorder and has panic attacks in the airplane is usually more afraid that he will get so anxious that he will go crazy in the airplane.
That's right. That's right. That was so you can have the fear of suffocation.
Yeah.
Was the one thing that gave her the panic attack. Then I had another patient who he had to sit in the first row and had to be right on the aisle with the idea that somehow or other he could make an easy exit from the plane. It's kind of imagination. But if he could not do that, then his anxiety would build up and he would, he had a fear of, well, that he would want to exit, that actually the urge to escape would be so great that he'd have to get up and he'd lose control because of the urge to escape. But somehow he was reassured when he sat in the aisle in the first row. So that's another.
That's what we call a safety behavior. A safety behavior.
Right.
His coping strategy to try to reduce his anxiety.
That's right, and it did not really work.
Yeah, because it prevented him from finding out that didn't matter how bad his anxiety got, he wasn't going to lose control.
Yeah, that's correct.
Sorry, that sound is super awful. In case you can't tell, the sound system in here is probably from the 90s. So, you know, it's not the best. Okay. Like I remember having these speakers when I was in college in the early 2000s. Okay, so next we're gonna start talking about OCD. And there are a lot of misconceptions about OCD as well. In terms of what it actually is, what it looks like. We tend to see it in movies only portrayed as like people needing to wash their hands and things along those lines, but OCD can manifest in a lot of different ways. So this is and one thing I should say real quick is that there's now this category in DSM-5 for obsessive compulsive and related disorders. So in addition to OCD, it includes body dysmorphic disorder, which is essentially where you think a part of your body is like disproportionately large or weird. The clearest example I have of body dysmorphic disorder is Michael Jackson near the end of his life. If you think about how many cosmetic procedures he got, how many surgeries, right? People with this disorder, just like they're never satisfied with their appearance. Hoarding is an OCD, obsessive compulsive or similar disorder. Trichotillomania, which is hair pulling. So people with trichotillomania will just sit and pull out their hair when they're stressed. And then excoriation, which is skin picking disorder. And it's similar to trichotillomania, but you like scratch your own skin, scratch off scabs, things like that. And the reason they grouped these together now, what they said in the book is, this reflects the increasing evidence that these disorders relatedness to one another, both in terms of symptoms and the treatments that work. So in OCD, you have obsessions, and these are persistent and recurrent intrusive thoughts, images, or impulses that are disturbing and just, the term I have here is inappropriate, but not like, the way we use inappropriate. Basically, like they don't match what's actually going on around you. Compulsions are thoughts or activities to suppress the thoughts and provide relief. And these can involve repetitive behaviors. Again, like I said, that's usually shown in the media, like hand washing. Yeah.
Could it just be, like if someone were like broken through the door, they have to do it like 4 times a
Yeah, exactly. Yeah, that's such a good example of these repetitive behaviors. So for some people, it's checking. So like they unplug their curling iron, but then they like have to go check whether they unplugged it like 4 or 5 times before they leave. Yeah, exactly. I had a friend in college who had OCD, and just like our campus, our main path, my college campus was lined with trees, and he counted his steps between the trees. And if he didn't get it quite right, he would like kind of back up a step and do it. He was on the ballroom dance club with me, so I think people just thought he was like dancing, so we could kind of hide it. But yeah, I mean, it certainly affected his life, obviously. The other thing that you can have as compulsions are covert mental acts. So things like just counting without a behavioral manifestation, praying, or just self-punishing thoughts, things along those lines. So obsessions are thoughts that are, they feel intrusive. They feel like somebody else put them in your brain. And they feel foreign for that reason. And if you try to just ignore them, it makes it worse. Basically, it triggers anxiety, and you just can't. So they take various forms. I'm just going to pop them all up here real quick. So wishes, impulses, images, ideas, doubts. And then the themes that they have, again, typically people think of the dirt contamination theme, but that's only one way OCD can manifest. Sometimes it's violence and aggression. Sometimes it's orderliness. Everything has to be just so. So if you've ever seen the show Monk, he's a good example of that. Religion. So some people, it's like there's like a religious guilt to things. You have to do things a certain way, or you will be punished somehow by your higher power. And also sexuality. So again, these are the common ones, and the picture that I have here is Howard Hughes, and him being portrayed by Leonardo DiCaprio in the movie The Aviator. So Howard Hughes had very severe OCD that went untreated, to the point that at the end of his life, he just like shut himself in a room he could control, basically. Compulsions are these quote unquote voluntary mental behaviors or mental acts. You choose to do them, but it doesn't feel like a choice. It feels like if you don't do them, something horrible is going to happen. They feel mandatory, they feel unstoppable. And the person may recognize full well that these are irrational, that these are not actually going to fix what's going on in their mind. But they don't feel like they can stop them because they believe that a catastrophe will occur if they don't do them. Also, performing these behaviors will reduce the anxiety related to the obsessions, but only for a short amount of time. And so this is why the behaviors will develop into rituals. Some people who have the contamination version of OCD will wash their hands so often that their hands actually get raw and start bleeding. They'll spend hours a day performing these checking behaviors. So cleaning, checking, repeating things over and over, ordering and arranging things, counting. And so I have a quick video of John Green, who some of you may know from YouTube and some of you may know from reading his books, but he has OCD, so he's going to talk about what it's like for him.
Good morning, Hank. It's Tuesday. This video is about my mental health, but I want to say here at the outset that I am not a psychologist, and that in general, I think we should listen to experts when it comes to mental health and also when it comes to other things. But I can only speak to my personal experience. Okay, so it seems to me that the stuff happening way down inside of us is difficult to talk about, partly because those experiences aren't really accessible by the senses. You can't usually see or hear psychic pain, and it's difficult to describe without simile or metaphor. Like, I might say that it feels like there's a void inside of me, or like my insides are twisted, or like my brain is on fire. I can say what it's like more than I can say what it is. So I have obsessive compulsive disorder, which is mostly seen in the popular imagination as being about like excessive hand washing or neatness or whatever, because those are things you can see, you know? They're not like the formless, insensate horrors of psychic pain. They're behaviors that you can like portray in a movie. But for me at least, there's a reason the obsessive comes before the compulsive in the name. So I experience these obsessive thought spirals in which intrusive thoughts, that is like thoughts that I don't want to have that seem to come from outside of me, sort of hijack my consciousness. Now everyone has known some version of not being able to choose their thoughts. Like after you lose someone, you may find yourself thinking about them all the time. You may see a sunset and think about seeing a sunset with that person, or you open a car door and remember driving with them, etc. But for me, these obsessive thought spirals happen all the time, and they can take over for days or weeks or months. Like I might worry out of nowhere that my food is contaminated or somehow poisoned, and then suddenly that will be the only thought I'm able to think, the thought I'm either thinking or distracting myself from all the time. And when that gets bad, I can lose all control over my thoughts for an extended period of time, to the extent that I can't follow what's happening in a TV show or read a book. This is exhausting, of course, but it's also kind of terrifying because one, I can't stop being scared of the thing I'm scared about, and two, if I can't choose my thoughts and I am at least in part made out of those thoughts, then am I actually the captain of this ship I call myself? And the more you think about that, at least for me, the more it becomes sort of the premise for a horror movie. Right, so the compulsive behaviors I use to cope with these obsessive thought spirals, repeatedly checking my food for contamination, for instance, or spending hours Googling what will happen to me if I eat moldy bread, those are for me ways of trying to comfort and calm myself. Like, I'm not checking over and over again to be eccentric or whatever, I'm doing it because I cannot stop obsessing over the fear that I might have eaten living mold, and I will do whatever I can not to be strangled by that thought. Mental illness is highly stigmatized in our culture, but it is also sometimes romanticized. We see TV shows where in order to catch a terrorist, a mentally ill person must go off their meds, or we see obsessive detectives whose obsessiveness allows them to crack cases that others couldn't. That kind of thing might be true to some people's experiences, but it hasn't been true to mine. Like, I don't feel like my mental illness has any superpower side effects. In fact, when I'm stuck inside a thought spiral, I find it very difficult to observe like anything outside of myself. I become a terrible detective. So when I started the book that has become Turtles All the Way Down, I wanted to like try to find form and expression for this way down, non-sensorial experience of living inside of thought spirals. The book is fictional, totally fictional, but it began for me with thinking about what it would be like to be this one particular 16-year-old girl, Asa Holmes, who's trying to be a good daughter and a good friend and a good student and maybe even a good detective, while also living with terrifying thought spirals that she cannot see or hear, but that are nonetheless very real. So like that's a bit of an introduction to the story and how I came to write it. I also want to say to any good morning.
So I just thought that was really great because he talks about his lived experience of this disorder, what it's like to live with it every day, right? And how he's channeled it in particular into his art. So this is what happens in OCD. So you've got the obsessions that causes anxiety. The compulsions help to sort of mitigate that anxiety, gives you relief for a little bit, but then those obsessions come back. And that's why it's these, I love his description of it as a spiral, because you just get stuck in it like a whirlpool. All right, so next we're going to talk about post-traumatic stress disorder. So the psychological stress disorders include those related to trauma, but then also just those related to severe psychological stress. So we're going to talk specifically about trauma here, but there are also things like adjustment disorders that are specific to stressors you're going through. So during and immediately after trauma, many people become highly anxious and depressed. That's a normal reaction to trauma. Where it happens for some is that those feelings will persist well after the trauma. And the precipitating event is usually actual or threatens serious injury to yourself or other people close to you. So these are the two big ones that we'll talk about. So acute stress disorder is essentially your symptoms begin within a month of the trauma you experienced, and then they last for less than a month. PTSD is where your symptoms develop anytime following the trauma, but have to last longer than a month. So you could develop acute stress disorder, but then the symptoms just don't go away after a month. And then you are diagnosed with PTSD. And in fact, that's the case for 80% of people who develop acute stress disorder, that they will go on to be diagnosed with full PTSD. The only reason we have acute stress disorder as a diagnosis is to help treat people who that is their experience, that it is this sort of short-lived thing, because it's still very, very distressing. So these are the symptoms of PTSD. It's a very complex diagnosis. And as you'll see, as we go through these symptoms, the two people will both have the diagnosis of PTSD. It could manifest in them in very different ways. So the first thing that you have to have is exposure to some sort of traumatic event. So actual threatened death, serious injury, or sexual violation. And one of the things I like that they changed in DSM-5 is they indicated that it can happen through media if that's your job. So for example, I saw a vet when I was working at the VA that his job in the Iraqi war was to sit in a tent all day with TVs from closed circuit feeds, from people's body cams, and just watch everything happening all over the country all day. So even though he wasn't out there actually experiencing the traumas, he was forced to watch it, right? And so technically at the time, it was before the DSM-5 came out, like that was sort of iffy for a diagnosis, but my supervisor and I were like, no, this is traumatic, even if it's through media. So I'm glad that they added that. And then you have one or more of the following intrusive symptoms. So you have recurrent, involuntary, and distressing memories. They'll just sort of pop into your head, almost like the compulsion or the obsessions in OCD. Recurrent distressing dreams, nightmares. Dissociative reactions such as flashbacks. So a flashback is where you actually feel like you're back in the moment of that trauma. So especially Vietnam era vets, a lot of what you'll see is if like a car backfires, they'll hit the deck. Because to them, that sounds like a bullet. For a lot of our OEF, OIF, so Iraq and Afghanistan vets, they'll all of a sudden something when they're driving will remind them of like driving down the road in country. And so they'll start driving in the middle of the road, like over the yellow line, because that's what they had to do to avoid improvised explosive devices when they were there. I had a client who had been sexually assaulted, and she would be having consensual sex and have a flashback and feel like she was back in that moment, even though her partner was very caring and loving, right? And then significant distress to exposure of any reminders of the events. And then marked physiological reaction. So things kind of like a panic attack, heart speeding up, breathing, shaking, things like that, to something that reminds you of the event. You're going to avoid stimuli associated with the events, and this can often be very problematic because it might mean you disconnect yourself from everyone who you were in the war with, right? So now you lost part of your support system. For one of my clients who had gotten out of the military but was working civil service still, he left the room every time they talked about the war. While he was working on an army base, they talked about it a lot, right? So it started to interfere with his job performance. And then you have negative changes in your thoughts and your moods, like the inability to remember important aspects of the events. And like neurophysiologically, your brain does that on purpose to try to protect you, basically. Exaggerated negative beliefs about yourself, and persistent negative emotions. And then the changes in arousal and reactivity. The biggest one here is hypervigilance. So always being on guard, always kind of keeping an eye on things. And this can manifest behaviorally in different ways. So I had a vet who had knee problems. A lot of the vets who came back from Iraq and Afghanistan had knee problems because they were carrying around like 100 pounds of equipment every day. But he would still patrol his several acre property every night because of his hypervigilance. The most often way you see this manifested is military personnel, law enforcement personnel. If they go to eat at a restaurant, they'll sit in the corner or with their back to a wall so they could see everything and no one could sneak up on them. If someone is able to sneak up on someone with PTSD, they have what they call an exaggerated startle response. They'll jump a mile, or for example, one of my friends saw a client who, when his kid woke him up, he didn't know where he was and he grabbed his kid by the throat. The kid ended up being fine, he didn't hurt him, but obviously like the kid was upset that dad did this to him, right? So then you had to like teach their small child, like, don't wake daddy up when he's sleeping. And sleep disturbances in general, trouble falling asleep, trouble staying asleep. And obviously you're going to get significant distress or impairment for this. And you really can be diagnosed with PTSD at any point after the trauma. When I was at the VA in 2009 to 2010, we were diagnosing people from the Vietnam War still. And that's largely because unfortunately some of those folks had been self-medicating with alcohol for years. And that can mask a lot of things like sleep disturbances, right? Because you get yourself so drunk, you just kind of pass out. And so when they got clean, then the PTSD symptoms came back out. All right, and I have a video where people talk about what it's like to live with PTSD. I want to give a quick heads up that they do talk about specific traumatic experiences. So if you're experiencing something like a sexual assault or like a motor vehicle accident, this could bring something up for you.
It's like living with a leash on a little bit. You can do some stuff, but every now and then you remember that it's there.
I was living in Japan during the earthquake in 2011.
A few weeks and months of political unrest while I was living overseas. We lived with bags by the door ready to go in case we needed to get out.
I found out in 2008 I had PTSD, complex PTSD, but I think the diagnosis should have probably been made when I was 14 years old.
I was raped, and as a result, I live with PTSD. The civil war in Lebanon broke out in 1975. I was only 17 years old. I lived through that for about 12 years.
As it kind of sunk in, I started to feel really guilty because I had always associated PTSD with people who had been to war, and I just didn't think I deserved it.
And so that's something I'll say really quickly. Until the 1970s, we never diagnosed people with PTSD other than soldiers. And then people started looking at, again, people who had survived things like fires, motor vehicle accidents, sexual assaults. And they realized like these symptoms are identical, they should have the same diagnosis. But for a long time in its history, PTSD was called things like shell shock because they thought it was only related to war.
The PTSD triggers, they ambush you. You don't know when it's gonna come. It's sort of the unknown. Every day you wake up and you don't know if you're going to have a trigger today.
I was at a movie and there's a part where this woman got trapped in a car. I had a serious panic attack.
There was a song that was talking about like shooting and armed robbery, and just hearing that song, like, that was all it took.
Something happened when I was 13, and when my trigger happens, in that moment, I am 13.
Usually the sounds of jet planes overhead would trigger off the memory for me of those days. It would make me feel weak in the legs, and my memory will go back to that time trying to look after my children when they were little and protect them. Yeah, all I had to do is hear a jet plane and that's where my mind will go.
At times, it has literally felt like I'm dying. You feel like you're never gonna get past this. One of the things that's
The one thing I want to say really quickly is that the word trigger or triggered has been really misused in our culture, where people are like, oh, I'm so triggered by your comment, right? But it has, as you could see, a very real diagnostic meaning for people with PTSD, that it's something that reminds them of their traumatic event and brings them back to that moment. So it's really sad to me that it's been sort of misappropriated.
helped me a lot was group therapy. This happens to more people than you think.
Start to have a conversation with this thing that you have.
I did counseling for 2 years in college, and it felt like that got my life into a pretty manageable place.
I am trying to build up the courage to attend a support group.
I would have these days where you're just like, you know, there's nothing I can do to do anything that you're supposed to do. In group therapy, someone called it a lost day. It's such a simple thing, but putting the words lost day to those days helped me like overcome.
And I think accepting that is really important, and just being like, it's okay to like freak out and just be like, oh, this is scary, like, because it's scary.
And don't ever tell them to get over it, because it's extremely painful.
Yeah, you can't just get over a trauma, right? And yet people will tell this, I mean, well-meaning people, I think, who are like not understanding why their loved one is different after a trauma. They'll often do things like, you know, say, oh, can't you just be like you were before? Or can't you just like get over it? It's been however long. And no, you can't, right? It's your neurochemistry actually changes the way things operate in your brain when you experience a trauma. And so for some people, without significant help, they're just never going to be able to move on
It's
from it.
like-
And sometimes even with significant help, as you heard from these folks, it can be really hard. So here's some stats about PTSD. So lifetime prevalence of at least one traumatic event is about 50% for women, 60% for men. Somewhere between 7 and 9% of the general population meets criteria for PTSD, and more women than men. So after trauma, more women than men develop the disorder. We don't know if that's because of women typically having sort of a higher propensity towards anxiety anyway. And some events, in particular combat, natural disasters. So you heard the guy talking about being there for the earthquake in Japan that also started off a nuclear meltdown. Abuse, physical, psychological, sexual abuse, and victimization are more likely to cause these disorders than others. So this gives you some indication of that, in general with the trauma, your likelihood of developing PTSD is 8 to 10%. If you're wounded in combat, it goes up to 20%. If you're sexually assaulted, it's 50%. 50% of people who've been sexually assaulted go on to develop PTSD. Same for people who are prisoners of war. So I just want to like take a second and like let that sink in, how profoundly mentally affecting sexual assault is. The same as if you've been a prisoner of war. And then repeated high levels of combat exposure in Vietnam, 60%. I'm guessing we're going to see levels like that as we continue to gather data on our OEF, OIF vets, because they were often also, I had a National Guardsman and they don't have, their regulations are very different than like if you're just in the Army. And I believe he'd already been on 4 tours and they were going to send him back again. And he was such an interesting case because he had PTSD, but he told me like, I'm going back in a couple months and that's what keeps me alive when I'm over there. Like the hypervigilance was adaptive for him. And so I was like, I get it. Ethically, I can't cure you. You know, ethically, I can't try to help you, but please come back when you come back. All right, so now we're going to talk about the stuff that's really often shown in movies, the severe psychopathology. And we're going to start with schizophrenia. And I covered 2 main disorders here because I think they're often confused. So I'm going to start with schizophrenia, and then we'll talk about dissociative identity disorder as well. So schizophrenia is a disorder of psychosis. And psychosis is, sorry, let me just pull that up. Psychosis is the state of being profoundly out of touch with reality. So your ability to perceive the environment and respond to the environment is significantly disturbed. And this is also going to impair your functioning. Psychosis, we typically think of with something like schizophrenia, which is probably some sort of brain-based disorder, but it can also be substance-induced. So people can have psychotic episodes while taking LSD, for example, or as a result of overusing it. Or it can be caused by brain injury. They can also occur, psychosis can also occur in the context of a mood disorder. So I had a client who had bipolar disorder, and when she was in a depressive episode, she would hear voices telling her to do things like stick her arm in the oven and burn herself. She didn't listen, but obviously it's very disturbing to hear voices from your own head telling you to do that, right? And so, but most psychoses appear in some sort of disorder along the schizophrenia spectrum. The 2 main symptoms of psychosis are hallucinations and delusions. So hallucinations are false sensory perceptions. False sensory perception. So they're abnormal sensory experiences, hearing, seeing, smelling, tasting, feeling something that's not there. Visual and auditory, hearing, seeing and hearing are the 2 most common, but certainly people get them in other modalities as well.
They smell things.
Yeah, yeah. And really interesting, you get that in some other disorders as well. So like people with PTSD, we'll talk about like my vets who had been in the desert in Iraq talked about like the smell of sand. And I never thought sand had a smell before that. But yeah, and they'll like smell it when there's not actually sand around sometimes. Yeah, they can definitely smell things that aren't there, taste things, feel things, like feel like there's bugs crawling on them, things like that. And then delusions are fixed false beliefs. Fixed false beliefs. And they're often bizarre. They're often things that just don't make sense to someone who's not having this experience of psychosis. Okay, so what's the difference between schizophrenia and psychosis? So psychosis is a broad term referring to experiencing hallucinations and delusions. Schizophrenia is a type of psychosis that also has disturbed thought and language and behavior. So the way I once heard it described to me that I think is really good is you could think of psychosis as like a fever. right? Like you can have a fever for a whole bunch of different reasons. You can have a fever because unfortunately you have COVID, you have the flu, right? If you get the COVID vaccine, some people have a fever in response to it, right? Things along those lines. Knowing someone has a fever doesn't tell you what their diagnosis is. Similar here, knowing someone has psychotic symptoms doesn't tell you their diagnosis, right? You need to kind of rule stuff out and make sure you accurately diagnose schizophrenia. So there are two main types of symptoms that we talk about, but we'll also talk about some of the other symptoms as well. So the positive symptoms are sometimes called the type 1 symptoms, and these do not mean they're good symptoms. The positive means here is something added on above what normal people would experience. So pathological excesses, exaggerations, or distortions from what we think of as typical functioning, or the presence of something that's normally absent. So this would be things like the delusions, the hallucinations, disorganized speech, disorganized thought, disorganized behavior. Then the opposite are the negative symptoms, which are also called the type 2 symptoms. So these represent pathological deficits or the absence of functions that are typically present. So these include things that look like depression. Honestly, you get flat affect where you don't respond and sort of your emotions are always just kind of there. You don't get highs, lows, you don't express happiness or sadness in a typical way. And then lack of motivation, lack of speech. So the current diagnostic criteria will include both of those. So, and one thing I want to point out, I'm going to go ahead and just pop everything up here. I don't know why past me thought that like clicking everything was a good idea. Present me says no. But you only have to have 2 or more of these symptoms. So you could have someone who has hallucinations and negative symptoms with schizophrenia, but you could also have someone with delusions and disorganized speech, and like they'll be diagnosed with the same thing, but they'll look totally different. There was an article that came out, I want to say like 8, maybe 10 years ago now, that argued that schizophrenia, what we lump together as schizophrenia, might actually be something along the order of 8 distinct genetic differences. But as of now, these people would all be diagnosed with schizophrenia. So you've got your delusions, those fixed false beliefs, so someone believing that they're the Messiah. Hallucinations, those inaccurate sensory perceptions. Disorganized speech includes severe disruptions in the process of speech. Sometimes people aren't able to articulate words or bring together a coherent thought. In severe cases, sometimes people cannot speak when they have severe schizophrenia. Grossly disorganized or catatonic behavior. These are bizarre or disrupted behavioral patterns, things like dishevelment, uncontrollable childlike silliness, extreme agitation, inability to perform simple activities of daily living, like making your bed. It's interesting to note that some people argue that disorganized speech and disorganized behavior are actually their own categories of behavior. And I just realized that this little bracket here is somehow including the negative symptoms. So let me move it a little bit here. There we go. The joy of converting things from PowerPoint. But right now they're basically considered part of the positive symptoms. And then those negative symptoms we just talked about. Lack of emotion, lack of motivation, could also be withdrawal or apathy. And then their functioning is going to be very markedly impaired. One of the things we talk about with schizophrenia is the fact that like typically kids do better off than their parents. with people with schizophrenia, that's not true. And you've got to have the signs of the disorder for at least 6 months, with at least 1 month of symptoms in full and active form. But there are other, just like acute stress disorder, there are other diagnoses you can give someone until they've been at the 6 months. All right, so delusions. One thing I'll say is, like, using bizarre in our colloquial way, all delusions would seem bizarre to most of us. But the DSM distinguishes between bizarre and non-bizarre in this way. So bizarre delusions do not relate to ordinary life experiences, like the idea that a secret race of aliens is controlling your actions with invisible rays from their home planet. Non-bizarre have potential to relate to ordinary life experiences, like believing that you're being followed by the CIA. I had someone who came into our training clinic once when I was assistant director and told me that the CIA had been following him across 4 states, but they stopped, so that meant something. We did not treat psychosis in our training clinic, so I happily handed him a referral card and sent him on his way. So the non-bizarre are more grounded in reality, but they're still delusional. You can have delusions of persecution, the idea you're being attacked, followed, controlled. Delusions of grandeur, so belief that you're an especially important and powerful person, belief that you're a messiah, belief that you're someone from history like Napoleon Bonaparte. Delusions of reference is believing that external events are connected to you. So believing that the TV announcer is specifically talking to you and sending you coded messages. Delusions of sin is the belief that you're guilty for various sins you've committed, when in reality you haven't actually committed any of them and don't have anything to feel guilty for. You can also have hypochondriacal delusions, belief that you have some sort of deformity or disease or contamination and focus on illness. And the nihilistic delusions is the belief that the world is going to end. This is, you know, the people who would walk around cities with like the end is near signs. Hallucinations, as I mentioned, they go into senses. So visual, seeing things that aren't there, auditory, hearing things that aren't there. These involve things that are not truly present in reality. So thinking that you hear something in the pipes that talks back to you. Olfactory, what we talked about, smelling something that's not there. Gustatory, tasting things that aren't there. And then tactile, feeling things. As I mentioned previously, auditory and visual are the most common. And some people are very terrified by their hallucinations and others don't mind them. And there are even some forms of psychosis where people find their hallucination comforting. So for example, in the context of vascular dementia, which is dementia you get as a result of stroke or a series of mini strokes, some people will, no, I'm thinking of Lewy body dementia, which is like a different kind of gunk than Alzheimer's, but still gunk in the brain. But people will have hallucinations that are like their dead dog or their dead loved one hanging out. And they know they're not really there, but it's still like, they like having them there. So they won't necessarily tell people about them. So that goes into another thing. Some people know the hallucinations are not real. And others have a really hard time distinguishing between what's real and what's going on inside of them. So these disorganized speech or thought symptoms, loose association is a sequence of logically disconnected thoughts. So the problem is insects. My brother used to collect insects. He's now a man 5'10". You know, 10 is my favorite number. I also like to watch TV, right? Like, I guess I could almost follow a thread, but it's hard. Neologisms are made up words, saying head vise for headache, or this desk is a cram style. He's an Easter horned head. Clang associations are nonsense sequences of rhyming like sound words. I'm out, spark shout, shoot me, shoo me, shoo, baby shady lady. Echolalia is repeating verbatim what people say. So if you ever did this with a sibling or a friend as a kid, she's copying me, she's copying me. Like they're not doing it to be funny or annoying, they just do it. And sometimes they also have echopraxia where they repeat the gestures of others. So someone with echopraxia, when I'm doing this, when I'm talking, they would repeat what I'm doing. And at its most extreme, you have word salad, which is they'll just spew out a random collection of words. The really interesting thing with word salad is if you don't listen to the words they're saying, but just sort of the tone and flow of their voice, it can sound like they're saying normal sentences. They'll still have rise and fall, but it'll be completely nonsensical. So the grossly disorganized behavior is a wide variety of bizarre or disruptive behavioral patterns, but the most extreme one is catatonia, which is a psychomotor symptom with ranging from extreme immobility and unresponsiveness to extreme agitation. And what you see here is what's called waxy flexibility, in which the patient will hold weird postures for hours. And if you were to go up to them and try to like help them so their limbs don't fall asleep, I don't know if anyone had those Gumby dolls as a kid, like where you can kind of like mold them around. It's like that, right? Where they'll just sort of like they're made of clay or Play-Doh or something. Alrighty, we'll talk about the negative symptoms and some of the other severe psychopathology on Monday. Everybody have a good weekend. You too.